I'd now like to welcome Dr. Vivienne Ralph to talk to us about IgA nephropathy and kidney transplantation. I met Vivienne at one of our national medical meetings about 18 months ago, I think, when she was talking about her ideas for this project and how it was going to develop. So when we were organising today, it seemed like a great opportunity to invite her back to report on progress. I did initially get an out-of-office reply from her, but fortunately the whole family have come to Cardiff. So thank you very much for all of you giving up your time to come and talk to us. Thank you.
Hello. So yes, my name is Vivienne. I'm currently working at King's College Hospital. Well, I'm on maternity leave, but that's where I'm based at the moment. And I'm doing a PhD in kidney transplantation and IgA nephropathy. And that's based at King's College Hospital. So I'm delighted to be here to talk to you today. So do I press this one? Yeah. So what we'll talk about today, and just to mention, please interrupt at any questions throughout or at the end. I'm very happy if I can at all to answer anything. So we'll talk a bit about kidney function. I know John's already done that, so we'll do that briefly. And then when I was putting together this talk, the last couple of weeks, I was thinking what I would want to know if I was in your position about transplantation. And I suppose the first thing is, will I need a transplant? And then what's the criteria for being allowed to have a transplant or being well enough to have a transplant? What's the criteria for donation? Because you might have some very eager friends or relatives that want to give you a kidney. And how do we work you up for a transplant? How your life will change after transplant. And then a question that I often get in clinic is, can my IgA come back when I have a transplant? Okay, so in terms of functions of the kidney, I know you've been through this a bit, but essentially the kidney is a large filter that takes out the toxins in your body through urine. It also helps to remove any medications that you might be on, that some of the waste products are removed through the kidney. And a lot of you will know that the kidney goes hand in hand with blood pressure, because a lot of the time we're trying to give you blood pressure tablets. And so that's regulated with a hormone called renin. It helps a lot with your bone health with vitamin D. And also it helps to produce red blood cells, which stops you being anemic. And anybody who's had anemia will know that you feel pretty rotten with it. So yeah, and oh yeah, of course, to maintain your salt and fluid balance. And anybody that's had kidney failure will know that fluid is such an important thing. We go from telling you to drink loads of fluid to drink very little fluid. You get swelling throughout your body. It's a very fine balance and can be very uncomfortable for patients. So will I need a transplant? As we've mentioned a couple of times today, not necessarily. Just because you get a diagnosis of IgA nephropathy doesn't mean you'll need a transplant. I'm sure there's people in this room that have had IgA for 20 plus years and haven't come to the stage where their kidneys have failed. But how can we predict this? Now, I know John talked a bit about this, but essentially it's us getting an idea from your kidney biopsy, because we're looking at how much scarring is in your kidney biopsy, and then we use a prediction tool. But also, if we see that you have 70% scarring, then that's an indication to us that the kidneys potentially in the not too distant future might get into trouble with declining. Also looking at your blood and your urine over different time points. So if we're seeing a decline of a certain amount each year, that gives us an idea again if you're going to need a potentially renal replacement therapy is what we call it, so dialysis or a transplant. The most important thing, so as nephrologists, we love figures and we love biopsies, but the most important thing is how you're feeling as your kidney declines. So some people, as their percentage of the kidney drops, will feel not too bad, whereas others will get a lot of different symptoms. And as we were talking today, and Christina was mentioning about loin pain, it's really a basis of what your symptoms are like, and that gives us an idea of how we need to plan for the future. So does anybody recognize anybody on the slide? Yeah. So more importantly, what's the thing that all these people have in common? They've all had a kidney transplant. So what I would say is that obviously these are quite extreme examples of very famous sporting people and actresses and singers. But having a kidney transplant doesn't mean that you can't go on to have a very exciting life and achieve very exciting things. And all of these people have done that, and they still have to go through the same process as you would. And it's just important to know that actually the reason for a transplant is for us to give you your best possible quality of life. So what if my kidney function does decline? So we talked a little bit about dialysis, and I'm sure that some of you have had dialysis in here and probably know a lot more about the experience than I would. But looking at it, so number 1 and 2 are the types of dialysis. So one is hemodialysis, and that white machine that the gentleman is hooked up to, that acts as the kidney. So it takes the blood out of your body, cleans it the way the kidney would, or filters it, and the blood goes back in. That happens 3 times a week in a dialysis unit or in the hospital, and it lasts about 4 hours at a time. And it's quite onerous because a lot of our patients as well, it depends where the space is. And working in London, there's a lot of different dialysis units, and we try and accommodate to make sure you're in your closest one. But sometimes it involves travel. Not everybody has a car. Not everybody feels well enough to drive to and from dialysis. And so then that's dependent on hospital transport. So it really does take up most of the day for patients who are dependent on transport as well. So it's quite onerous. We do offer home dialysis, hemodialysis for patients, and we try and support where possible for that if patients are able to have dialysis at home and also have the support. And then they'll often dialyse overnight and have their day free, and that removes the restriction of hospital. Peritoneal dialysis is often referred to as tummy or abdominal dialysis, and basically the lining of your abdomen acts as a filter. So that first bag that you see hanging up is full of molecules that help draw out waste, and then that waste it gets filtered through the peritoneum and comes out in the other bag. People do this throughout the day. They might leave the fluid in their abdomen and then drain it out in the evening, or people do it overnight. It's important to say with dialysis, you can still work, you can still have, do things that you enjoy in life, but there is restriction. And that brings us to kidney transplant. So we'll talk about that in a minute, but that is pretty much the optimum renal replacement therapy that we have. And number 4 is conservative care. So sometimes patients will decide that they don't want dialysis, they don't want a transplant, or they're not well enough for that. And in that case, our whole team, nurses, doctors, physios, pharmacists, dietitians, will all work together to make sure that we can give you the optimum quality of life with medications and also with lifestyle adaptations. So who can have a transplant? So it really is a case-by-case decision. So it's not restricted by gender, ethnicity, age, and it really is just based on the patient at the time. It's worth saying that the patient has to be a consenting adult that has the capacity to go for the operation and also to take medications and to do all the hospital appointments afterwards and before. And then we look at your fitness level. So in terms of the fitness level, what I mean here is we're looking at your heart function, your lung function, your past medical history, whether you've had any cancers previously, and then come all the investigations. So we're pretty rigorous with our investigations to make sure that you're in the best possible health and we have all the knowledge that we need to before you have a transplant. So that involves, bloods, urine, CT scan to look at the vessels of where the transplant might be implanted. We do a echo or a jelly scan of your heart. We look at your lung function. And so we want to make sure that, we're giving you your best possible chance of, recovery and feeling well during this. So who can donate a kidney and how do I get a transplant? So there's 2 types of transplant you might be aware of. So there's a living donor transplant and deceased donor transplant. So living donor is, what your friends or family might want to do for you and donate you a kidney. These can be related. So again, family members or unrelated, spouse, friend. I even had a patient recently who a colleague that they'd worked with for only a year wanted to donate their kidney. So that was pretty generous. And it's worth mentioning as well that there's something called altruistic donors. So some people take it upon themselves to donate a kidney to someone that they've never met and never will meet. And so that is a very generous very generous donation. And then what you may have heard of as well is the kidney sharing scheme. So I think the kidney sharing scheme is really remarkable and really special. And that is essentially a wonderful idea where if you want to donate your kidney to, say, your spouse, but you're not a match, then that kidney can go into a pool of kidneys, somebody else who does the same thing. You'll swap around the kidneys to get the best possible match. And therefore, we can match more kidneys, more people can have living transplants, and more people get to have their transplants. So it's wonderful. Workup, anywhere between 3 and 6 months to do all those investigations. And I know that most centres are really good at the moment at trying to, do as many investigations on one day as we can, so you don't have to keep coming to the hospital. Deceased donor transplant. So I'm sure you've heard of this before or seen it on TV, etc. But it's where when someone dies, they have decided to donate their organs, or their next of kin makes that decision after they die, if they haven't. And so this is based on the best match countrywide. Wait time can vary anywhere between 2 and 3 years. And essentially, it's quite a complex matching process that's run by NHS Blood and Transplant, and they have a website that discusses this. But you're looking at how your kidney matches to somebody else with blood type, tissue typing, age, comorbidities, and how long you've been on the transplant list as well is also taken into account. So it is quite a complex matching process. So how long will it take to get the transplant? So deceased, we said 2 to 3 years. When you get a call for a transplant, when you become active on the transplant list, you will have a call from your team, be brought into the hospital, and then they will discuss the type of kidney it is, i.e. the kind of age range that it's from, somebody in their 50s to 60s, or they'll tell you about the different medical conditions that they had, and ultimately your medical team or your transplant team will tell you if they think this is a good match, and then you'll make a decision together. Living donor, usually about a 6-month workup, and age consideration. I put that in there because we do think about age in terms of, ideally we wouldn't put a 70-year-old kidney into a 21-year-old who needed a kidney transplant. We want to give everybody the best chance at the longest time for their kidney to last. So where possible, we match there as well. And yeah, we mentioned the blood group and the tissue typing. So the operation, your transplant team will go through this with you before. But what I wanted to point out here is that your kidneys at the top, your damaged kidneys, they don't get removed, only in some specific conditions. And in IgA, normally that we don't need to remove the kidneys. And so they just remain in. And then your transplanted kidney gets transplanted in your pelvis, either on the right or the left. So just where your hip bone is, just in that area. And that's because it's easy for us to then plumb in the renal artery and the renal vein into your vessels, and also to plumb it into the bladder. So it sits just in the pelvis on the right or the left, depending on your anatomy. So some of you have had transplants, and so if you haven't had this experience, or you've had something that you think I'm missing here, please do let me know, because obviously I see it from my side and not necessarily from the patient's perspective. So you have all your appointments in your workup, then you either become active on the transplant list or you plan a day for your living donor donation, a date in the future. When you're admitted after the operation, you'll be in for an average of 7 days. And this is for us to keep an eye on bloods, how much urine you're producing, how much fluid you're taking in, how well you feel afterwards, how much the kidney is functioning. And you'll see, your medical team and your surgical team every day. You'll see the pharmacist to go through the different medications you'll be on. And then when you are discharged, we follow you up very closely. So about 3 times a week initially, sometimes twice. And then this starts to tail off a little bit more as your kidney becomes more stable. And hopefully around the 3-month mark, we'd be able to have you down to about once a week. And some people get there quicker, some people it takes a bit longer, but essentially once you become part of the kidney transplant family, we hold on to you very tightly. So how will it change my life? So if you are on dialysis, immediately it's hugely less restrictive. You now don't have to adhere to certain times for your dialysis. You don't have to think about doing it overnight. Once the kidney transplant is stabilised, you can think about travelling without all the stress of trying to organise dialysis elsewhere or bring all your dialysis bits and pieces with you, which puts most people off travelling when they're on dialysis, really. So you're suddenly a lot less restrictive. The main thing is symptom improvement. You swapped kidney for kidney, so like for like, and instead of having that kind of filtration for a number of hours a day or a number of hours a week, you're now getting it second by second or minute by minute, and so your symptoms start to improve greatly. Medications and risks. So medications can feel a bit overwhelming after a transplant, but again, our pharmacy teams are wonderful at supporting, as are all the doctors and nurses. You will be on immunosuppressants. Your body is clever and it thinks the kidney is, a foreign object that it needs to get rid of. And so we have to give you immunosuppressants. So we trick the body into realizing that the kidney is part of you now. But at the same time, because we do that, it's a bit of a double-edged sword. We can reduce your immune system, that you're more chance of infections. So we give you medications to help prevent that where possible, or at least reduce the chance of that. We're then really rigorous about taking care of the kidney. So we'll make sure your blood pressure is well controlled. If you're diabetic, we'll really focus on that, and your cholesterol. And you'll also be on blood thinners to prevent any clots, because we have, plumbed it into different vessels. Now, will IgA return after my transplant? So this is one of probably the main questions that you want to know. So we don't know for sure. We don't know who it will return in or who it won't return in per se at the moment. We monitor very closely, looking at your urine, your bloods, and if we have any concern whatsoever, we would recommend a biopsy if possible. If you do get recurrence, this doesn't mean that you'll necessarily lose your kidney or that you'll have kidney failure. So one of my areas of research that I'm very interested in is looking at who gets recurrence, why they get recurrence. Is there a particular time point that they get this at? So if I know that in the future, then we can monitor more closely around that time and help to prevent this. There's still lots that we don't know, but we're working with RADAR, which we mentioned a few times, which is the National Registry of Rare Diseases. And there's a lot of information with IgA there, because a lot of kind patients like you have consented to let us have their data. And we're looking at that. So hopefully in the next year or so, we will have an idea. We have about 2,000 patients, and we'll have an idea of who gets it, or, how quickly they get it after a transplant. And then using that, we can build on further research and, plan that way. The problem is that if you're trying to look at that in each hospital that you're in, we only have a small number of IgA patients. So in King's, in the last, 29 years or so, we've had 89 patients that we have in our books with IgA that have had transplants. And so, if you're thinking about that over a long period of time, now suddenly we've got 2,000 in RADAR, so that's really promising, and hopefully we can get a lot out of that. And treatment options. I know we've talked a lot about that today. So there's no sanctioned treatment for recurrent IgA in transplants at the moment. But a lot of the work that I'm doing in my research as well is we know what the disease process is in IgA, more or less, in terms of we're trying to interrupt it with different drugs that John mentioned today. And we would hope that if we can show that the disease process is the same in the transplanted kidney, because we've interfered with your immune system, so we can't just assume that. So if we can show that in our research, then maybe we can look at doing a bigger trial. And there is certainly trials happening already or about to happen for treatment options in transplant. And it would be our hope that a lot of these treatments that are in IgA will translate to working in recurrent IgA. And so it is a very, exciting time for us to be able to offer patients treatments. Probably doesn't feel as exciting for you, because I know you're going through all of this. But as John was saying, at least we have something coming in the pipeline rather than nothing as previous. So how long will my transplant last? It's dependent on the kidney, the health of the kidney, your health, what happens after you have the kidney. Some kidneys can last over 30 years. On average, about 15 years. You often see with improvements in immunosuppression, they last much longer. And also it's worth noting, because a lot of young people get IgA, you might get a transplant, and then if it fails after 20 years, you're still quite young. So what do we do then? You can have another transplant. And we have patients in our clinic that are on their third transplant. And just because one transplant failed doesn't mean the next one would. It all depends on matching, and medications are improving all the time. So it's not necessarily the same course. I have seen somebody with 4 transplants. Yeah, she's on a 4th transplant. I don't think I've seen anybody with more than that. They were all over the place, which made it a nightmare for biopsying. I just had to guess. I was like, which one's working? So yeah, it's a nightmare for biopsying. So resources, you're all aware of the Leicester IgA Nephropathy Facebook group and YouTube channel. That's very helpful. It was helpful for me to get an insight into what patients are asking and what kind of questions people have. And then these are all reliable resources that I also use. So take-home messages. Not all patients with IgA will progress to end-stage kidney disease. That's very important. There's 2 types of transplant, living and deceased. Living is optimum because we preempt you going into renal failure, and therefore hopefully we can skip the dialysis part. It doesn't always work, but that is our hope. But a lot of our patients have deceased transplants and are doing very well with them. Planning and preparation is key, and I know we've been talking about being your own advocate, which I know is difficult a lot of the time with doctors, but it is important to start asking about planning and preparation. And actually, sometimes your nephrologist will be delighted that you brought it up, and they can start that process. You will not necessarily get recurrence of IgA if you have a transplant, and there's a lot of ongoing research into treatments. Thank you so much for listening, and any questions? So basically, it depends a lot on patient symptoms, but we would class probably kidney failed at about 15%. It can be, some centres do 17 or 18%, and really, if we know you're heading that way, we can transplant before you even reach that if it's a live donor. Obviously, with the deceased donor, you don't have that kind of choice. But yeah, we would try and do it before you need to have dialysis, and also in line with your symptoms, so we can eke it out if you're feeling quite well. But again, it just depends on the patient.
After transplant,
yeah.
Kidney function level.
Sorry, can I just give you a mark?
After the transplant, what sort of kidney function level would you expect to see?
So actually, the last patient that I saw before I went on maternity leave, she had her kidney transplant, she had IgA, and she started, her eGFR was around 50, then it went up to 60, then 70, so it just kept climbing as time went on. We'd expect your creatinine to normalise afterwards, and we would hope for that. Yeah.
What was the timescale of that?
Days. But it's not always that way. Sometimes it can take a little bit longer. And I have seen patients who have come out of having their transplant, and with the deceased donor transplants, sometimes they've travelled all the way across the country. They've been on ice, so they're a little bit slow to wake up. And I've seen patients that have actually had a rough few weeks at the start where the kidney hasn't worked, and then it has kicked into action and been absolutely fine. So that is, we don't think a kidney hasn't worked if it's not working straight away. It just needs a little bit of time to wake up. Yeah, a little bit of support.
Hi, I'm a kidney transplant patient with IgA recurring, though fortunately kidney function is okay at the moment. One thing that struck me and my donor, who was my wife, was that this risk of IgA recurring, we didn't really know about it before the kidney transplanted. It wasn't really mentioned. There was a whole raft of risks pointed out to us in terms of infections and lifestyle and all that. But the risk of IgA recurring wasn't really highlighted, though I'm sure both of us would have still gone ahead as the transplant was the best option in the circumstances. But I wonder whether it should be drawn to people's attention.
Yeah, I think, that you're definitely not the first patient that said that to me, actually, which I was surprised by. But I think it is always trying to find that balance of saying, yeah, you probably would still go ahead with it. I think patients should know all of the information, but it's finding that balance of trying to, make sure that there's not immediate fear that the IgA is going to come back, and be more hopeful and uplifting about it as a doctor, but also finding the balance of being realistic.
I'm a transplant patient. My transplant was just over 3.5 years ago, and I don't know how long the gentleman's in front of me was, but it was explained fully to me prior to that the IgA could actually come back. Might not, but it could.
Yeah, that is good to know. Yeah, I think healthcare professionals would intend to mention, but yeah, I'm sure sometimes it doesn't happen. And it's worth saying, actually, yeah, you can just be called any time of day or night for a deceased donor transplant. So yeah.
Ross Evans from Kidney Wales. Just going to say, one of the things we hear a lot from people that we support is you put the figure up of 2 to 3 years as a wait, and many wait a lot longer. That can often be a factor in decision making around treatment options. As a healthcare practitioner, do you think there needs to be more awareness made around the need for transplantation and organ donation? Obviously, the UK now has adopted the opt-out law process. I think Wales led the way in that. But there hasn't been a lot of sort of general awareness since then. Consent rates we're hearing are slightly starting to drop. So just be interested to hear your perspective as a healthcare professional.
Yeah, I think always I think if people knew, if they don't have strong religious or cultural beliefs about transplant donation or about organ donation, I think if people knew how much it can change someone's life, most people would be on board. So as much awareness as possible is good. I know we have the opt-out now, but still, unless a family is happy to go ahead with that, we still wouldn't recommend donation for that patient. But yeah, I think always. And that's always great as well when patients speak out or do like their patient stories about how transplant has changed their life. And I know it's not all wonderful. I know there are downsides as well with all the medications and things. But if patients speak out about how much it has changed their life, that encourages more people to think about donation.
Can I ask?
Mm-hmm.
So in Wales, we've got you're automatically opted in.
Yeah.
Yeah. Do you still have to ask the family?
Yes. Yeah. And we wouldn't proceed if the family wasn't happy necessarily, because we never want organ donation to be something negative or harrowing for a family. So it's always a big discussion. Yeah.
And if it's known that somebody is on the donor register, families are very much more likely to agree with going ahead than if they haven't made a decision.
With regards to supply issue, is there much research being done into alternative options or animal kidneys or anything like that?
I know that I've just read the headlines, probably much like yourself, about pig transplants, but not I haven't really looked into it beyond that much, so I don't know.
I've spoken to so it's very interesting. There's some transplant surgeons in the United States who get consent for patients who have died and are on the ITU, their relatives, and those are people that have had pig kidneys transplanted into them. And then for a 24-48-hour period, and then the patient is only alive because they're on the ventilator, etc. And then everything's switched off, but there's all the consent and everything has happened. And so they are starting to study genetically modified pig kidneys. It's not got very far, but it is fascinating the work they're doing in a very, very highly regulated way, that people have agreed that they're happy for their body to be used almost after death, after death, while they're still being maintained on the ventilator, to start understanding how you might put a pig kidney into a human being, what the response is to that. But it's very early days, but it is happening.
Yeah, and
That's
to follow
interesting.
on to that, there's a very recent publication of a successful kidney transplant into a human, and I'm aware of a second one, and the FDA has just approved phase 1 clinical trials for pig transplants. I think, as John says, these are very highly genetically manipulated kidneys so that they are accepted for human transplant. So it is going to be very interesting to see the direction of travel with that over the next few years.
Yeah, it would be great.
Just in relation to that, so I'm 5.5 years post-transplant. If anybody's any questions about it, by the way, you can ask from a patient perspective. I don't mind
That'd be
answering
great.
my experience. But I did talk to a vet actually randomly about kidney disease, and he said he listened to a podcast about using genetics or stem cells from the same donor, living donor, that eliminated the need for
Immunosuppression.
immunosuppressions. I'm just wondering, is there any further information on that, or?
So yeah, that was done recently at the Evelina. So in the hospital attached to Guy's and St Thomas's, there was a young girl who needed a kidney transplant from a genetic condition. And so what they did first was, I believe that they did a bone marrow transplant from her mother. And so far, I mean, I haven't followed it up in the last few months, but at least 6 months ago, she was removed from all immunosuppression after 1 month. But that's about the extent that I know, and I'm sure we'll hear more about how that goes as time passes.
Yeah, so she also needed a bone marrow transplant for an unrelated condition. So a bone marrow transplant at the moment needs extremely significant immunosuppression to basically remove your own bone marrow. And there's a recognised mortality with that procedure itself. So long term, it's great because you'd have a bone marrow transplant, then a kidney transplant, and come off immunosuppression. But at the moment, there's a very high risk early on, which is why I think it's not been more widely accepted. But as things improve, that might be another option.
That might be the future of it.
If someone's had a transplant and IgA comes back, is the option of having a kidney from a live donor still available?
Yeah, if your kidney fails. So if you have your first kidney, your IgA comes back, and that kidney transplant fails, then yes, you can be considered for live donation. Yeah, that doesn't negate it. Partly, yeah.
So can you have a deceased kidney and a live kidney?
Yeah.
I would follow up on that, but if somebody had a kidney and the disease recurred quickly and the kidney failed quickly, and they had a second transplant and that happened again, I would then have concerns about a third transplant and would discuss that very carefully with the donor recipient. So there are individual circumstances that I think we'd always take into account.
Yeah, because you'd never want, when you're taking a kidney from someone, you never want to cause more harm than removing the organ or leave them in a worse way than they would have been otherwise.